Welcome to this week's lecture on Chapter 2. Now, this week we're going to be looking at some of those really fundamental developments that have happened in healthcare from the legal perspective, political perspective, economics, organization, and professional that really have transformed healthcare to what was basically kind of like a human service. If you think about how healthcare originated, and often with religious orders or early nonprofit organizations, where you're looking at basically human services, to where it is a big organization, a big business that it is today. So we'll be looking at some of those landmark developments in those areas. We're also going to be talking about third-party payers. That's not going to go away. It's a very, very important area. And we're going to start our discussion on public health and the Affordable Care Act, again, which will be a narrative throughout this course. So with that introduction, let's go ahead and get started on the lecture for Chapter 2. This week's busy word cloud highlights the terms that are the basis of the chapter's content. Many of the acts here that you see are legislated by the federal government as well as healthcare organizations and agencies. By no means is this a comprehensive list within this word cloud, but it is reflective of the major benchmarks of the United States healthcare system's development and implementation. As always, it's a good idea to spend some time researching them further to get a better understanding. Also, you may want to discover their timeline and their effects on each other and the healthcare delivery system as a whole. I mentioned in the first slide that healthcare began as a simple human service. Well, that's true. Physicians were the deliverers of healthcare services and worked relatively free from scrutiny as to what they did and where they did it and who they treated. Physicians were the sole decision makers. This practice was upheld by the American Medical Association, or the AMA, who went on record to saying that no third party must be permitted to come between their patients and his physician in a medical matter. The AMA was addressing insurance providers, prepaid insurance contract services, and the insurance workers carried from their employers to cover workplace illnesses and injuries. Now you'll notice a few seconds ago I said his, and that was actually what was in the AMA statement in 1934. They used that instead of their, they used the word his pronoun. Women were still not treated totally as rightful people at this time. So it's amazing how things have changed just within one lifespan. The United States does lag behind the European counterparts when it comes to providing healthcare services to their populations. Much of this has to do with the United States being a relatively new country, meaning that there's been a shorter period of time to develop the infrastructure necessary to support functional and a robust healthcare system. But as early as 1915, when there was a push for compulsory health insurance, sound familiar? This argument is 100 years old. National health coverage is not a new idea. So before Obama, before the Clinton administration, before you or I were even born, before all of our patients were born, this was a national conversation. But many events in history have put this conversation on hold. Then it sputtered, and then it was on again with really minimal movement towards fruition. Well, change takes time, and the part of the change that takes the most time is getting buy-in to anything that's new. Back in 1919, when the American Medical Association was adamant in its opposition to compulsory government-supported health insurance, in their collective opinion, the interference it would create between doctors delivering care to their patients was considered too extreme for that organization. Physicians were against the coverage because they thought it would reduce their incomes. Third-party payers play an important role within healthcare. During the Great Depression of 1929, Baylor University Hospital was one of the few hospitals in the country to recognize that now more than ever people needed help paying for medical care that they received. They started experimenting with insurance plans to help reduce out-of-pocket costs. Baylor enrolled just over 1,200 teachers who paid. Third-party players play an important role in healthcare. During the Great Depression of 1929, Baylor University was one of the few hospitals in the country to recognize that. And what they realized is that people needed help in paying for the medical care they received. Now, they started experimenting with insurance plans to reduce out-of-pocket expenses. Baylor started with enrolling just over 1,200 teachers who each paid 50 cents a month. That guaranteed them 21 days of hospital care. Well, this later became the model for Blue Cross. The plan slowly gained momentum, and by 1937, they had already had 600,000 members, 26 plans, and on top of that, the American Medical Association finally came on board and began approving plans. Well, sort of. The AMA still thought insurance model was unethical. It was a puzzle to work out how to pay for medical costs. A committee researched how to overcome this obstacle in 1932. For 5 years, they researched and came to the conclusion that group practice and voluntary medical insurance was the best route to take. But that decision was not unanimous. The dissenters cited voluntary health coverage would cause destructive competition among professional groups and lead to inferior service. But physicians did back the government's plan to reimburse them for free services to low-income populations, and that's a historical fact. The role of third-party payers, physicians, facilities, and the government is explored in more depth in every chapter that we're going to have going forward. The government has instituted many healthcare initiatives to address healthcare concerns. The three major healthcare concerns are, again, cost, access, and quality. You'll hear this time and again, and it's always a good news, bad news story. Delivering all three of these at the same time has met with stumbling blocks. With the enactment of Medicare and Medicaid, access to services has improved, so that's the good news. Usage of healthcare services and their associated costs have skyrocketed, so we got a good news and bad news story here. And quality issues have increased, so there's some bad news. Again, hard to do all three. At the beginning of the lecture, I promised to introduce you to public health. Now that could be its course all unto itself. But the topic of public health, and we'll just give you a brief introduction here, has evolved in this country and is discussed at later length throughout the course. The introduction I'm giving you has to do with public health's role in addressing the cost, access, and quality in relation to healthcare delivery. Please note that the government is painfully aware of the barriers to these concerns and would really like you to know they've been working on it. But the government, as we know, especially now, is a political machine and so is pressured by powerful lobbies and special interest groups to maintain the status quo, and by the public on the other side for changes and reform. The medical and hospital lobbies want provider-friendly legislation, which merely opens it to the interpretation of physicians, administrators, as well as other healthcare professionals. Now, the federal government made an amendment back in 1965 to the Public Health Services Act to establish the Regional Medical Program Initiative. This is a nationwide network of medical programs in designated geographic areas to address the leading causes of death, which are heart disease, cancer, and stroke. Through this initiative, regional medical programs improved their educational and clinical resources But patient outcomes for those conditions did not improve, and prevention measures were not increased, and costs were not reduced. A similar program, the Comprehensive Health Planning Act of 1996, was enacted. This act was intended to promote comprehensive planning of rational systems of health care personnel and facilities in certain regions requiring federal, state, and local partnerships. Also, there was a requirement that a majority of consumers on every decision-making body. Soon, special interest groups created conflict of interest within the groups concerning funding, such that the programs were eventually deemed ineffective in achieving their goals. Public health's primary focus of disease prevention is often overshadowed in this country by the curative medicine focus. Nevertheless, the focus is there for public health to continue on promoting prevention with exercise, immunization programs, and even healthy eating programs. The cost of healthcare is escalating at an alarming rate. The growth of spending on healthcare has outpaced the rest of the U.S. economy. Government programs like Medicare and Medicaid have not contained costs as we hoped. As I mentioned before, it's almost an impossible balancing act when we look at those three areas of cost, access, and quality that really hasn't been mastered as of yet. When I say HIPAA, what do you think of? Probably patient confidentiality. But there is more to HIPAA than you think. When HIPAA was enacted in 1996, the main goal of it was to keep insured people who lost employer-sponsored health care when they lost or changed jobs, allowed them to maintain insurance through that time period. HIPAA also regulates the circumstances in which an insurance plan may limit benefits for pre-existing conditions. But what it also did was change how medical records are kept. It required all medical records to be electronic by October of 2003. This part of HIPAA is known as administrative, or I should say administration, simplification. Well, that proved to be anything but simple to implement, and we even haven't gotten there quite yet, but we're getting close to that, and it's already 2016. Between the creation of the Office of the National Coordinator for Health Information Technology in 2004 and the American Recovery and Reinvestment Act of 2009 in response to the Great Recession, healthcare is involved in a high technology upgrade, not necessarily in the diagnosis and treatment side of things, but in medical record keeping. Another big benchmark in healthcare is the Oregon Death and Dignity Act, enacted in November 8, 1994. The Act protects the right of terminally ill adults living in the state of Oregon to request prescription medications to end their lives, thus legalizing physician-assisted suicide. The condition of the patient must meet that they are incurable, that the disease is irreversible, and within reasonable medical judgment would produce death within 6 months. In a survey of Oregon physicians, 2/3 believed physician-assisted suicide is ethical in appropriate cases, and 46% said they might assist a patient if they met the requirements of the Act. Not only must the patient meet certain requirements, but the physician has requirements as well. The physician must ensure the patient is fully informed on their condition and prognosis and the risks likely to result in the medication and alternatives, including comfort care, pain control, and hospice. So again, they have to have all of these things informed to the patient, and it has to be done by the physician. The consulting physician must attest that the patient's judgment is not impaired and that the decision is fully informed and voluntary. The patient then is asked to notify their next of kin. Now, after a 15-day waiting period, the patient must again make the request. If the patient does, the physician then can write the prescription for assisting the terminally ill in ending their suffering. Then in 2008, we have another benchmark where the state of Washington enacted its own Death with Dignity Act along the same lines as the Oregon Act. And then not too long after that, in 2009, we have the Montana Supreme Court ruled to maintain the state law that protects doctors from prosecution for helping terminally ill patients to die. Now look for more decisions on both sides of this argument, as well as legislations for and against the right of terminally ill to end their lives and physicians to assist that as well. As of 2014, we have 5 states have laws upholding a patient's right to die, which in essence is physician-assisted suicide. Something else has happened to shape healthcare, and that is the internet. The image on this slide tells the story. All aspects of patient care have an internet connection. Consumers use the internet to get test results, look for a physician, read reviews on providers and physicians, and then communicate with their physician. Physicians use it for billing, patient record acquisition, sending images for reading, and for scheduling patients. Insurers and hospitals use it to connect with the patient for billing and appointments as well. Smartphones are outpacing computers and tablets in helping patients and providers with apps basically aimed at their needs. So you're going to see more smartphone usage in the future. Consumers are using apps for price comparisons, for medical services, and for pharmaceuticals as well. Another thing, keep in mind, the consumer side of healthcare is really arising because of the shift with patients now taking on additional out-of-pocket expenses. They're becoming more savvy shoppers and using the internet to compare those services that they're going to have a larger portion in paying for than maybe what they have in the past. The Patient Protection and Affordable Care Act of 2010 has forever changed the landscape of healthcare. The broad mission of the ACA is to bring affordable healthcare coverage to millions of uninsured or underinsured Americans by 1. Providing new customer protections, 2. Improving quality and lowering costs, 3. Increasing access to affordable care, and 4. Holding insurance companies accountable. Notice that in those 4 bullet points that I've just mentioned, we have covered the big 3: the quality, the access, the affordability in there. Now, the rollout of the Act spans 9 years with sets of benchmarks to be met every year. Now, your text gives a synopsis of what each year brings, so that does a good job with that. In 2015, improving quality and lowering costs takes the form of physician reimbursement guidelines. No longer will physicians be reimbursed by volume of their work. Rather, it will be based on the quality of their work. Physicians who do better will get more money. Higher patient satisfaction and better health outcomes will be rewarded. Also in 2015, there is an increase in federal match for CHIP. States will get 23% increase in their CHIP match rate up to 100%. CHIP eligible children excluded from the program because enrollment caps are eligible for tax credits in the state's health insurance exchange. So they're covered in another area. Now, do you remember what CHIP stands for and its function? Here comes a bonus time. So if you've been in this lecture long enough, this is for your reward here. Tell me both again what CHIP stands for and its function in an email, and I will give you 5 bonus points. All right, so there's your bonus point opportunity. Now, let's get back to our slide here. So as you read through the plan, keep in mind predicting the ultimate success of the Affordable Care Act is still kind of up in the air. Many states have still brought suit against it for mandating insurance coverages. We've got a political election on the horizon. The regulations of the Affordable Care Act aside, think about the nation's economy, though. Politics and healthcare choices of the consumer. I, for one, think it is also interesting, and I wonder if patient outcomes will ultimately be the winner in the end, which I absolutely hope so. We desperately need a solution. The Affordable Care Act is a good attempt at that solution, obviously still fraught with some controversy and potential pitfalls. But until I see something else, I think this is our best thing to get the costs, the quality, all of that under control. Well, again, thank you for joining me for the past 20 minutes. Make sure you watch the videos, study the terminology presented in your text, do a little research on anything that might be a little bit murky for you, again, through your research outside of the textbook. If you need help, remember, I'm just an email away, or you can text message me. Also, you can post your questions in the virtual office, but I prefer if you do have a question, please text me. That way I can get back to you sooner. You can find my phone number in the course news. All right, hope everybody's having a great week, and I'll see you in the next lecture.